How's everyone doing today? All right, we got an energized crowd. That's great. So some of you guys I've seen before, others I have never met, and future patients, I'm sure. But this is a really important talk. It's dear to my heart. My father had prostate cancer. I originally wanted to be a plastic surgeon, and then things happened in my life, and here I am as a urologist now talking to you guys about how to take control of your own destiny. And I think, PSA is the crux of what we need to talk about. PSA, it's kind of like your crazy uncle. It's the best thing we have, but it's not great. And until we find something else, this is what we're utilizing. But I want to kind of give you guys the control of making decisions for yourself based on the information I'm going to give you today. Because there's things that we can do in addition to PSA to help you decide, A, should you be worried? B, should you get a biopsy? C, should you get treatment? And so it's not, as much as it's my job to make decisions, I want to kind of give the power in your hands. So first and foremost, what we're going to talk about today is screening. Should we do it? When to start? Who are the groups that are at higher risk? How do you screen? How often? And then what can we use in addition to PSA to make decisions? Use of advanced imaging, MRI. I think this has changed drastically how we manage prostate cancer in 2024. And using a prostate MRI, not just for diagnosing prostate cancer, but also treating prostate cancer. And we're going to touch on something called focal therapy. And that means therapy that's focused. And then once you've had your biopsy, what do you make of the results? Sometimes patients come to my clinic and they say, it doesn't say cancer, but it doesn't say normal. What does this mean? Should I get a repeat biopsy? Should I be worried? And we're going to talk about these acronyms, high-grade PIN, ASAP, AIP, and then kind of leave you guys with future directions, things that I'm excited about and where we can go from there. So this was a slide when I was graduating from my fellowship, and you can see, if I can focus your attention on the left, this is the incidence of cancers in men. And you can see that I put arrows in 2008, 2012, and then 2014 and 19. The reason I put it in 2008, because this is when the U.S. Service Preventative Task Force recommended against screening in men that were above the age of 75. And so you could see there's a decline in the incidence of prostate cancer because we're screening less men. And then in 2012, the U.S. Preventative Service Task Force recommended against screening for all men for prostate cancer. So you could see there's a drastic decline in the incidence of prostate cancer. But then from 2014 to 2019, there was a rise. And what we started to see was a 3% annual increase in the detection of prostate cancer. But also something I call a stage migration is we started seeing more advanced prostate cancer. So when I started my residency in Toronto, I rarely saw men come to the emergency department in urinary retention because of prostate cancer. And then when I became a fifth-year resident, I started seeing men coming in and they were unable to pee, and we would get imaging and they'd have prostate cancer spread throughout their body. And so currently what we're seeing is a 4% annual rise in advanced prostate cancer. Now, this is just a slide showing why we screen. I know there's a lot of information here, but these were three major trials that were done, PLCO, ERSPC, and Göteborg. And at the top is just the amount of patients that were enrolled in these trials. So these aren't small trials. And what they showed was that, if I can focus your attention on the two on the right, that when you screened patients with PSA every 4 years or when you screened every 2 years, there was a 21% and a 42% reduction in prostate cancer mortality. Now, you may ask yourself, okay, well, what about the first trial? The first trial showed no difference. And this was a PSA that was done annually. And that study showed no difference in prostate cancer mortality if you were screened or if you weren't screened. So basically, if you had your PSA checked or not. The problem with that study is that 80% of the group that was supposed to not be screened actually received PSA screening. And so we call that contamination. And so it's very hard to come up with conclusions from that trial. And so based on the two trials on the right, you can see down here, these are acronyms, but these are guidelines. And this is in favor of screening. And in fact, recently, the U.S. Preventative Service Task Force actually removed their recommendation against screening. And so now it's supposed to be a shared decision-making model. So when should we start screening? Well, 45 to 50 years of age, and if you're a higher risk population, it's a little younger. But let's talk about who are the higher risk groups. So age, certainly, we know prostate cancer is a disease of the aging male. My old chair of Toronto used to say aging is not for the weak. And so we start to face more comorbidities. So you can see here that as we increase in age, there's a higher incidence of prostate cancer. But the important thing, there's a higher incidence of aggressive prostate cancer. So that yellow line is aggressive or high risk prostate cancer. And you can see as we get into our 60s and 70s, that rises tremendously. Well, what about a healthy lifestyle? So there's this thing called metabolic syndrome, and I think it's just medical term for being out of shape. So if you have obesity, if you have high blood pressure, if you have diabetes, if you have bad cholesterol, and you have a combination of 3 of those 5, you have something called metabolic syndrome. And is metabolic syndrome associated with prostate cancer? Well, they looked at just under 2,000 men from Finland who had no cancer diagnosis and had no diabetes, and they followed them for 13 years. And what they found was that at 13 years, those who had metabolic syndrome had a 2-fold increased risk of prostate cancer. And if you added obesity as one of those markers, it increased to 3-fold. And so what you can conclude from this study was that if you take control of your own health early on, you can reduce the chance of prostate cancer. So if you have a diagnosis now of prostate cancer, should there be a prostate cancer boot camp? Like, should we have at UF soldiers helping you guys run and reduce weight, things like that? Well, not necessarily. If you have an intense lifestyle modification, what's that mean? Vegan diet, strenuous aerobic exercise, stress management, there's a lower chance that you may come off of active surveillance. And for those who don't know what active surveillance is, it's when you have low-risk prostate cancer, but we just watch you. It's kind of like being on a salad diet because you have diabetes. So that's active surveillance. So if you have a very strenuous workout program and stress management program, the chance of coming off of active surveillance because your cancer is getting worse is lower. But if you do small things like try to have a healthy lifestyle, try to work out here and there, it would likely not make a difference. And so the take-home message from this is changes that have a large impact should happen early on. So if you do not have a prostate cancer diagnosis, beyond just for prostate cancer, lower your blood cholesterol, lower your chance of diabetes, lower your weight if you can. I understand these things are harder said than done. Some people have had knee surgeries, things like that, and they just can't run. But water programs, stationary bikes, there's things we can do to reduce your chance of prostate cancer, but also for cardiovascular health. Strong family history. If you have one brother or father, or you have relatives with one of the following: if you were diagnosed with prostate cancer at less than 60, you have someone in your family who died of prostate cancer or had metastatic prostate cancer, or you have these sorts of cancers in your family, so you have breast cancer, ovarian cancer, then you have a 4-time increased risk of prostate cancer. And most men that come to my clinic have one relative or more that have prostate cancer. And so this is something, if you have it in your family, make sure you get checked. Just a list of genetic conditions. I highlighted BRCA2 because I want to just talk on this one. BRCA2 is actually identified, it stands for breast cancer gene 1 and gene 2, and this was found in breast cancer, but there's been some association with prostate cancer. In fact, if I just show you this point at the top, if you're a BRCA2 carrier versus a non-BRCA2 carrier, you have a higher incidence rate of prostate cancer, you have a younger age of diagnosis, but you also have more clinically significant prostate cancer. Now, what does clinically significant mean? It means prostate cancer that poses a risk to your life. Okay, so there's some prostate cancers, they say you die with it, not of it, but the meaningful ones. Now, who should get germline testing? Well, if you have a family history of germline mutations. If you don't know if you do, then you probably don't. For the most part, patients who know they have it, they'll come in, they'll say, I had 2 sisters who had ovarian cancer, I have a brother who has prostate cancer at 58, I'm a little worried. Those are the kind of patients where we should do germline testing. If you have a strong family history of prostate cancer, if you've been diagnosed with high-risk prostate cancer, and that's a definition that we make. And so you'll come into the clinic and you'll say, hey, this is my biopsy results. If you have the highest risk prostate cancer, this is where we'll get germline testing. If you have metastatic disease, so disease that's spread out of your prostate, or if you're very young at diagnosis, it's very rare for a 45-year-old or 46-year-old to come in with aggressive prostate cancer. And so something's going on beyond just your odds ratio of why this person has prostate cancer. And I want to touch on this high-risk group. So this is the Black community. The Black community has a lower rates of screening, and yet they have a higher incidence of prostate cancer, 1.8-fold increased risk of being diagnosed with prostate cancer, and a higher incidence of advanced prostate cancer. And look at that, a higher mortality rate, 2.2-fold. So it's very unfortunate that a group that gets screened less has higher mortality. Matter of fact, they should be screened more. And if you look at these population models, this just shows you that a curve that shifts to the left means that it's a younger age at diagnosis. And so on average, no matter what population models we've created in the United States, African American men get diagnosed with clinically significant prostate cancer at a younger age. Now, if we are to look at asymptomatic, so men who have no symptoms who come in, a doc, I feel fine, and they get diagnosed with prostate cancer. Even if they're diagnosed at the same stage of prostate cancer, Black men will have a 44 to 75% chance of progressing. That's higher than non-Black men. And then finally, the only interesting thing I want to highlight is, let me see if I can, my pointer, this cohort here. So if you get diagnosed on biopsy with low-risk prostate cancer, you should have low-risk disease. And so why do 1 in 5 men, despite being low-risk prostate cancer, have genetics that are high risk? And that's the red line. Whereas if you look at non-African American men, no one who has low-risk prostate cancer has high-risk genetics. And genetics means the biologic undertow. So when I do a biopsy, it's just a snapshot in time. It's like taking a picture of a Ferrari. You don't know if the Ferrari is going 100 miles an hour or if it's in a parking lot. We just take a shot and we say, okay, this is your current diagnosis. But who knows in 5 years what's going to happen? And so the biologic undertow is much higher for African American men. Then when we look at African American men, they benefit from more screening. The number needed to screen is 5 to 9 versus 7 to 11. And another thing that's interesting is that this is in 45,000 US veterans. They saw that if you did annual screening rather than once in a while screening, that there was a reduction in mortality for Black men, but this wasn't the case for non-Black men. We should screen in all, but maybe we should screen more often in Black men. So added to our guidelines as of last year, it says clinicians should offer prostate cancer screening at 40 to 45 for higher risk groups. And who are those high-risk groups? Well, these are the people I've just mentioned. And this is a picture I think is really nice because if we treat everyone the same, we're actually not doing them justice because some people need more care than others to achieve similar sort of outcomes. And so for me, for prostate cancer management, I usually look at equity. So I can, personalize care for individuals who are at less risk, average risk, and high risk. So what are our guidelines? If you have a high PSA, we got to repeat the PSA. One value means nothing. And then this MRI finding. So I get really disappointed when I have a patient who comes in who's had a biopsy without an MRI. I mean, this is in our guidelines. So it's not an opinion, this is what needs to be done. So I kind of think of prostate cancer like peppers. How do we know which one is the ghost pepper, hopefully there's no pepper experts in here, but Trinidad Scorpion, Carolina Reaper, you may have an understanding what's a bell pepper, but once we get in the weeds here, how do we know? They all have similar shapes, similar appearances, and yet the Scoville units are drastically different. And so it's the same thing with prostate cancer. We have a diagnosis, but how do we know which ones are lethal and which ones are not lethal? Hey doc, everyone tells me you die with it, not of it. Yeah, that's a proverb, but maybe that's not your case because prostate cancer is still the second leading cause of death in men in terms of cancer. So in terms of the ones that are risky, this is the intermediate risk, high risk, and very high risk. And this is not an adjective, but when you get diagnosed with prostate cancer, we stratify you by risk. We say, okay, are you low risk, very low risk, intermediate risk, high risk? Where do you fall in this spectrum? The ones that pose a risk to your life is this spectrum. The one that poses zero risk to your life is this spectrum. Notice how I added this one in this group, but also added this one in the low risk group. It's because this is a very interesting population. Some people do very well, some people do very poorly. And this is why it's important for you guys to see urologists and for us to kind of further explore this. So if you have very low risk, or you're in that group that has really small amounts of intermediate risk prostate cancer, we can do something called active surveillance. So for those who don't know what active surveillance is, it's monitoring you. We don't treat you, we don't do surgery, radiation, we don't do focal therapy, but we don't say goodbye. We follow up with PSAs, with repeat MRIs, with biopsies and further tests. So PSA, who here has not heard of PSA? Okay, good. So we have a group that knows PSA. Well, PSA is an interesting test because if it's high in an individual and you repeat it, 25 to 40% of the time, it'll go back to normal. And so PSA is not specific and it's not sensitive. So in isolation, it should not be used as a predictive tool. So how can we use further things with PSA? Well, we can use age. So PSA of 4 in a 45-year-old is too high. PSA of 4 in a 75-year-old is actually kind of low. And so when you have a gentleman who comes in and goes, hey, I have a high PSA and it's 5 and they're 85, I tell them, hey, you're doing great. You know, there's no worries here. And so we have to realize that there's an age category associated with PSA. Now, if we were to use age cutoffs, we would actually be detecting more curable cancer in younger men and preventing the diagnosis of cancers that will pose no risk to people's lives in older men. So something to take into consideration. PSA velocity. This is probably the highest reason I get referrals from other urologists or other family physicians. And yet PSA velocity in and of itself is one of the lowest predictors of prostate cancer and lowest predictors of upgrading if you're on active surveillance. In fact, a rapidly rising PSA velocity is actually associated with inflammation. So then you may ask yourself, well, how do I use PSA? Well, PSA density is a great test. And PSA density is important, but it requires imaging. Because what PSA density does is it divides the PSA by the size of your prostate. And the size of your prostate is determined by transrectal ultrasound or by MRI. And so you could imagine if you have a PSA of 4, for instance, but your prostate's the size of a walnut. That's a lot more concerning than if you have a PSA of 4, but your prostate's the size of a grapefruit, because you have less cells making more PSA. That sounds like cancer. But if you have a lot of cells making a little bit of PSA, that doesn't sound like cancer. And so it's important to utilize PSA density. And so when you guys have your PSA values, make sure you ask your family doctor, hey, should we get an MRI? Should we get an ultrasound? Should we kind of look into this PSA density action? And I just want to draw your attention to this curve. I don't want to get into the details and be too academic. It's mostly for take-home messages for you guys. But this green curve here, this is a coin toss. This means anything below this is less than 50%. Anything above this is greater than 50%. And you can see here, well, it's really hard for me even to see, but there's a line here, and that's PSA. And there's a line here, and that's PSA density. And so utilizing PSA density gives you a higher chance of identifying clinically significant prostate cancer than PSA alone. And so I encourage you guys to ask your family physicians for that. And you may say, well, what's a cutoff that I can use to be concerned? Well, we traditionally use the cutoff of 0.15, but this is a continuous spectrum. So if you have a 0.14, should we not be concerned? And if you have 0.16, all of a sudden we're concerned? No, it's a spectrum. And so 0.15 is just to help people kind of make clinical decisions, but I look at things on a spectrum. And if you've had a negative MRI, which means you've gotten your test and the radiologist, the imaging doctor says that we don't see anything concerning on imaging, but your PSA density is really high, that's concerning. But I use a higher cutoff if the MRI is negative. On average, people use the cutoff of PSA of 0.15. And if you've had a prior biopsy and it was negative, I keep that. If you haven't had a biopsy, I have a lower threshold for biopsy. Now, I don't know if you guys have noticed, but sometimes your PSA values will say PSA, and then it'll have other sort of nerdy words under it, like free PSA, free to total ratios, things like that. The bottom line is bound equals bad. Bound is bad. And so PSA should be free floating, but if it's bound to other protein, that's associated with a higher chance of prostate cancer. And you can see here that there's been some studies looking at over 3,000 men, and a low percentage of free PSA has been shown to be associated with prostate cancer. Now, look at how many things have come out in the last 15 years to help us make decisions for you guys and to have these discussions with you guys. There's a list of biomarkers, there's a list of tissue genomics, and are they helpful? Well, in the right clinical scenario, they are. They're helpful when we want to decide to biopsy or not to biopsy in a patient who's never had a biopsy. And can we trust the biopsy? So if the results are surprisingly negative, so a patient has a very high PSA, a very concerning PSA density, and yet their biopsy was negative, can we trust those results? And that's where biomarkers become helpful. They're not helpful if your risk of prostate cancer is already low or your risk of prostate cancer is already high, because what value does it add to my decision with you? We already know we either should do nothing or we should do something. So just to keep in mind, it's an expensive test. We have to be cautious with when we use it, and we use it when we're not sure. Now, this is what we use at University of Florida. There's many different types of biomarkers. They all have their values, and they're all interesting, but these are the ones we use here. I wanted to touch base on MRIs. I think this has been the greatest addition to prostate cancer diagnosis, but also prostate cancer therapy over the last 10 years. Just for you guys to know, MRI is an imaging modality. It's got 4 sequences. The T1 sequence, these are just the names of them. And by sequence, it's kind of like filters on a phone when you want to take pictures and slide through different filters. So T1 kind of gives you a broad image of what's going on. T2 kind of tells you where there's an area of concern. And then these are density, ADC and DWI. So prostate cancer, a lot of cells are growing. It's a denser area. And so you'll notice areas that have less diffusion of water molecules, and it'll look darker here or brighter here depending on the sequence that you have. And it's been standardized. We have radiologists who understand very well how to read MRIs and how to come up with a score of what is your probability of cancer. And we call that the PIRAD score. So you may see that on your MRI. It'll be a score from 1 to 5. And 1 and 2 is generally indolent, which means there's a very low risk of cancer. 3 is like, I don't know. The radiologist is like, I'm not sure. 4 or 5 is it's suspicious. And you can see here on the right is that the higher we go in PIRAD score, there's a higher chance of clinically significant prostate cancer. Matter of fact, if you look here, if you have a PIRAD score of 1 or 2, there's a 91% chance that your biopsy is going to be negative. And if you have a PIRAD 1 or 3, it's 87%. And so we use this as another feather in our cap to make decisions for you. Now, the reason why MRI is important and specifically dear to my heart is because there's a new reason why we utilize MRI, and it's not just for diagnosis, but it's also for therapy. And I call this the middle child, and I'll explain why I call the therapy that we employ here, we've started here as of 2 years ago, the middle child. These are 3 studies that changed my opinion of prostate cancer, and I don't want to go to too much detail, but I want to show you guys something that may be surprising to you. So these studies wouldn't even be able to be done nowadays because they're somewhat unethical. But in the 90s, what we did is we looked at 82,000 men, just under 3,000 of which were diagnosed with prostate cancer. And we said, would you be interested in this study where now you've been diagnosed with prostate cancer, but you're going to be randomized to either surgery, radiation, or active surveillance. We're either going to watch you operate or radiate. Are you interested? And these men said, okay. And we followed them for 15 years. And the 15-year outcome of this is that there was no difference in mortality. Whether you had surgery, radical prostatectomy, radiation therapy, or we watched, the chance of mortality was not significantly different at 15 years. And what they concluded, the choice of therapy thus involves weighing the trade-offs of the benefits and harms that are associated with treatment. So if you've had surgery, if you've had radiation, you're going to have more side effects than if you watch. And so this was the conclusion from this study. And these are landmark. This is New England Journal of Medicine, level 1 evidence. It's the highest level of research. If someone publishes in this, their career is set. So this is the highest level. And then we have 3 of them. This is a 20-year study, completely separate. There was no difference in all-cause mortality and no difference in prostate cancer mortality if you operated or watched for 20 years. And then this is a 29-year study. And what they saw at 29 years was that only patients who had greater than Gleason score 7 or had disease that was kind of poking out of their prostate did they have an advantage if they had surgery over nothing. So the question then becomes, why are we doing something? Well, those men, they may not have died of prostate cancer, but they would have had developed metastasis or other sort of symptoms. But it's also important to risk stratify. And what I say is, if prostate cancer mortality is low for most patients, no matter what therapy you choose, why not choose a therapy with less side effects? And so is there something that we can do between active surveillance and radical therapy? And I'm not saying radical therapy doesn't have its place. Matter of fact, it has its place, but it's in the higher risk group. It's in the groups that I've highlighted, the unfavorable intermediate risk, the high risk patients. I did 2 prostatectomies yesterday, and they were both patients that needed it. So we have to just be more careful to not over-treat men who may not need it. And if we do treat them, at least treat them with something that minimizes the side effect burden associated with treatment. And so what is focal therapy? Now, before I get to the details of this, I just want to get your attention. So focal therapy is like the word. I find the English language is very helpful because it just tells you exactly what it is. It's therapy that's focused. And I'm French, so words are very different in French. And so it's kind of like going to a spa. There's many different types of massages you can get when you go to a spa, but it makes you feel good. So focal therapy, there's many different types of focal therapy. You can laser, you can heat, you can electrocute, you can freeze, you can surgically remove part of the prostate. There's many different types, and different centers do different types of focal therapy depending on how they were trained. It's not that I prefer one or the other, it's just where I trained, we did it this way, and so I feel comfortable offering it to my patients. I don't have a preference or a non-preference. But this is a study that utilized HIFU, high-intensity focused ultrasound, which we have at the University of Florida. And high-intensity focused ultrasound uses ultrasound waves to pinpoint the ultrasound waves on a single area. And ultrasound waves are harmless. It's not radiation. It's just waves. And these ultrasound waves, when they converge on a single point, they become very hot. And so if we target a tumor that's visible on imaging, then we can burn that area while keeping the rest of the prostate structure unharmed. And why is that important? Well, what are the structures that are intimate with the prostate? The nerves of erections, the muscles that control continence, how you pee, the rectum, the urethra. There's a lot of intimate structures. And so if we can minimize targeting those areas and just treat the cancer, hopefully we're able to give good cancer control and minimize side effects. And so this study looked at 1,400 men, and they gave them this focal therapy, and they looked at outcomes. And I just want to draw your attention to the outcomes. So who was this population, the 1,400 men? Well, a majority of them had intermediate risk or high risk cancer. So this wasn't low risk groups. And if we look at what their 7-year failure-free survival, which means they were treated, and in 7 years, they didn't need any radical therapy because their cancer had come back. So 7-year failure-free, it was overall 69%, which means that 30% of men needed surgery or radiation because this focal therapy didn't work. But 70% at 7 years did not. So if you're a 75-year-old gentleman, a 70-year-old gentleman, there's a 7 out of 10 chance in 7-8 years that you're still free of side effects and just hanging out. Now, you may ask yourself, well, this is not perfect, but it's important to compare this to radical surgery. Radical surgery is not 100%. Sometimes I see patients that are a little surprised in my clinic. They're like, what do you mean if I have surgery or if I have radiation that there's a chance the cancer may come back? Well, it's because the failure-free survival of surgery is not 100%. The failure-free survival of radiation is not 100%. And I'll show you what those comparisons are so you guys can see, oh, this is the failure-free survival for focal therapy. This is the failure-free survival for surgery. Interesting. Now, the retreatment rate was 1 in 2. What does that mean? That means that if you are to have focal therapy, there's a 1 in 2 chance in 7 years you may need focal therapy again. But what is focal therapy? Well, it's an outpatient procedure. You come in 2 hours, you get treated, and you go home the same day. So it's less morbidity on the patient, but they need to realize that it's a double-edged sword, focal therapy, where the advantage is we're only treating part of your prostate. Well, the disadvantage is we're only treating part of your prostate. So we have to monitor things, and there's a chance that we have missed something. And so that's kind of the conversation we have with patients. But the retreatment rate is 1 in 2. But the failure-free of needing surgery or radiation because the failure was so drastic is much lower. And so and just so you guys know, the overall survival, I don't do focal therapy in high-risk patients, so the overall survival for me is 100%. Metastatic and prostate cancer specific survival, 100%. Look at those complications, 0.5% complications. That's less than 1 out of 100 men will have a complication from this procedure, and a complication, claviodendio 2, is a urinary tract infection, burning when you pee. It's nothing that requires major surgery. If you compare this to radical surgery, this is the comparison. So this is focal therapy at 7 years, and this is who was free of needing further treatment, who had failed. It's quite similar to surgery and radiation. When you get to the intermediate risk group, it's about 10% less good than radical therapy. Interestingly enough, the high risk group is quite similar. But this is the group here. So I tell my patients, if you are to have focal therapy, if you choose that you want focal therapy, you will have less side effects than if we have radical therapy. But there's a 10% chance that you may have worse cancer control. And this is something that's a trade-off that patients have to decide for themselves. I can't decide for you what you value more or less. Some people value erections, the young men, new relationships, things like that. They care so much about erections. Others couldn't give a you-know-what. Other people, continence is the most important thing. They don't want to leak. I had a patient who was climbing Kilimanjaro, and he was like, I would rather be continent and have some cancer than incontinent, and my quality of life just goes in the drain. And other people, cancer is more important to them. I don't know who I'm meeting that day, so I can't tell what they're going to prefer, but I can just give you the information, and you guys decide for yourselves, and I'm happy to help. In terms of side effects, no change in continence or sexual function with focal therapy at 2 years. Urinary symptoms return to baseline at about 3 to 6 months. Now, I'm not saying that this is going to be a painless, free of nothing. Patients still have it's still cancer surgery, but this is where we've come in prostate cancer management. If you're the right patient for this treatment, quality of life things can be mitigated. So it's really neat. So who is a candidate for focal therapy? We're starting to grow in the intermediate risk group. Low risk, I would say, it's good to watch. It's very rare that I would treat a low-risk patient. And there'd have to be an indication, which I have a few in my head, but for the most part, low risk, we watch. Intermediate risk, this is a great population for focal therapy. And then high risk, I would say no, as of right now, until we have better evidence. And then finally, in those who've been radiated, who have cancer come back, this is a tough population. And so in this population, it's kind of nice to consider new outcomes, because surgery after radiation, it's like flying in a winter storm. It's tough, it's hard to see, it's not advisable, complications can happen. It's not fun for any surgeon, because we like our patients. I don't want to see my patient wearing 6 pads a day because I didn't know where the muscles were. The muscles were completely shot and I had to go wider. So it's very, very, very hard to operate on a patient after radiation. And so hopefully we can have new modalities of treatment that can minimize side effects even in this population. But you may say, well, what's the odds of someone who's been radiated completely in their pelvis to have a recurrence? Well, 30 to 40% at 10 to 15 years. There's a 30 to 40% chance of a recurrence of prostate cancer if you radiate the pelvis. And so that shows you the difference between focal therapy and radical therapy. It's still not perfect. Interesting thing about radiation is if it comes back, it's more local than we think. About 50% reoccurs in the prostate. And it's actually more isolated than we think. About 50% of those recurrences that happen in the prostate happen in just one little section of the prostate. So focal therapy is a possibility. Because of this, it's been added to our guidelines as of this year. You can see here, in patients with documented prostate cancer recurrence after radiation therapy who are candidates for local therapy, HIFU. This has been added as of this year. Now, why is an MRI important? Well, an MRI is not only important for the diagnosing of prostate cancer, because I showed you guys the PIRAD score, but it's also important because it tells me if you're a candidate for focal therapy. It tells me how many lesions you have or how many areas of concern, where's that lesion located, how big is it, and where it is in relationship to your urethra, your rectum, your sphincter, all that stuff. But guess what? If you come in with a biopsy result and you haven't had an MRI, I can't help you. I can't offer you focal therapy, and now you have to get an MRI, but now your MRI may show something that your biopsy didn't. Now we have to go back to the biopsy, and it's a drag. And so I would say if you are planning with your family physician or your urologist to undergo a biopsy, request an MRI. It's in the guidelines. Like your insurance will cover it. So this is something that you need to take control of if you're in that situation or you have a friend that's in that situation. So focal therapy is an umbrella term for therapy that's focused. We talked about that. This is a list of focal therapy menus that we offer. Sometimes people come to my clinic and they say, hey, do you do this? Do you do that? Well, I was trained to do HIFU I learned this, and I'm learning this. And so in November, we're going to add cryotherapy. I'm going to Duke, to Dr. Plastic. He's done the most in the country. And it's very similar to nano knife. It's just this uses freezing, this uses electricity, and this uses ultrasound waves. But I utilize one of these three depending on what the MRI is telling me. And so I'm not just guessing. There's a reason why I do certain things, but that's what we have to offer at University of Florida. And we're really happy about that because it's helped out a lot of patients. We've done 45 this year. So it's been really nice. So switching gears a little bit, you get your biopsy and it's negative. Is it time to celebrate? Well, yes, you can pop a small glass of wine or a small champagne bottle, but it doesn't mean that that's it. You still have to follow your urologist because interestingly enough, 5 to 25% will be diagnosed with clinically significant prostate cancer in their lifetime for patients who've had a negative biopsy. And they still have a risk of prostate cancer mortality. We shouldn't just use PSA to make decisions at this point. This is why PSA density, MRI, biomarkers are really important in this patient population. Now, for those who have diagnosis that says it's not normal, but it's not cancer, what do we do with this? And it's all these nerdy words. High-grade PIN, what do we do with this HGPIN if it's on your biopsy? Well, studies have come out that show that if you have a biopsy that's negative, what is your chance of prostate cancer, not just grade group 2 or higher prostate cancer, but prostate cancer on your next biopsy? Well, it's 20 to 30%. Well, if you have high-grade PIN, what's your chance of prostate cancer at next biopsy? 20 to 30%. So you don't have a higher risk of prostate cancer than the general population. And so because of that, if you have high-grade PIN, we treat you just like the general population, and we just continue surveillance. MRIs, again, they've changed a lot of things. Prior to MRI, high-grade PIN was concerning. Now that we have MRIs, there's no difference between high-grade PIN and benign disease, and there's no difference between whether you have one core or thousands of cores of high-grade PIN. If there's going to be a lesion, we're going to find it on MRI, and that's going to be the difference maker. So high-grade PIN, don't worry about it. If you have this, ASAP, it sounds like you should do something, right? Well, ASAP stands for atypical small acinar proliferation. Your chance of cancer is actually quite high, 30 to 50% at next biopsy. And your chance of cancer that poses a risk to your life is 10 to 20. So if you see this on your biopsy results, make sure you speak to your urologist about making sure you have a confirmatory biopsy in about 18 months. This is another one, AIP. I'm just leaving them here for your information. This is something that's been seen a lot with clinically significant prostate cancer at next biopsy. So if you have this on your biopsy results, it's not cancer yet, but it may be cancer in the coming months. And so make sure you get a subsequent biopsy in the next 18 months. This is a summary of that. Just make sure, if you have this, please don't lose sleep over it. But if you have the other ones, we need to get a biopsy within 18 months. Now, PET imaging. I don't know if you guys have heard of PET imaging, but when I started my residency in Toronto, we would do CAT scans and bone scans to look for cancer that spread out of the prostate. What PSA value do you need for a bone scan to be positive? You need a PSA of 10. What PSA value do you need for a CAT scan to be positive? 32. That's pretty high. What about in PET scans? A PSA of 0.5 can detect prostate cancer in 38% of men. A PSA of 5 can detect 97%. So we've gotten a lot better in terms of detecting prostate cancer using PET scan. We get PET scans when patients have either PSAs that are coming back after surgery or radiation, or if they have high-risk prostate cancer, because we want to make sure that they don't have cancer outside their prostate. Now, another thing that's important, and this is just the take-home message here, and I've left some studies here for you guys if you guys are interested in reading, but a positive PSMA PET outside the prostate, almost certainly you have prostate cancer outside the prostate. So if you have a PET scan for high-risk cancer and this circle lights up outside the prostate, almost certainly it's cancer. But if a PET scan is negative, it doesn't mean you don't have cancer. That's the sense. See how it's a score from 0 to 1. Sensitivity means a negative study. Sensitivity is very low, but the specificities are high. And so what does that mean for me? So if I have a patient who has high-risk prostate cancer and I do a PET scan and the PET scan's negative, I'm still going to do a lymph node dissection. I'm still going to remove the lymph nodes beside his prostate because a PET scan is not telling me for sure that he doesn't have prostate cancer outside of his prostate. But if it's positive, I'm going to consider treating him like someone who has advanced disease. And so it's going to help men out if it's positive. If it's negative, it's reassuring, but at the same time, it doesn't preclude surgery with extended lymph node dissection. So what are the future directions for PET? PET is a good diagnostic test, but I'd like to see it more as a therapeutic test as well. Just like I told you that MRIs can be used to diagnose, but now it can also be utilized to treat with focal therapy. But can we use PET to guide treatment with focal therapy? And can we use PET to follow patients after they've been treated with focal therapy? So in summary, I think screening with PSA is important. We saw the U.S. Preventative Service Task Force actually rescinded their comments. It needs to be done earlier for high-risk groups. Elevated PSA does not mean prostate cancer. Do not freak out if you have a high PSA. Remember your age. Remember if you've had an MRI, focus on the PSA density, focus on the MRI results. PSA velocity may mean you have inflammation of your prostate, may mean you had a nice bike ride last week. Who knows? But it's the density in the MRI and the biomarkers that are very helpful. Before you are told to have a biopsy, I can't stress this enough, request the MRI, because if you don't have an MRI, it's very hard to offer focal therapy to you. And finally, consider focal therapy instead of radical therapy if you're cancerous focused. Thanks.
Great, thank you for that. We have a little bit of time for some questions now. Anybody have questions?
Yeah. May I ask you,
Maybe the
what's the
microphone.
PSA velocity? PSA velocity, can you define?
Yeah, so PSA velocity is just tracking how your PSA is changing over time. And usually it's done over a year. But sometimes men have, for instance, they've been checking their PSA over the last 10 years. And so there are these calculators online that what you can do is you can plug in the PSA, what year it's been done, and then it tells you your PSA velocity. Now, if you have a PSA velocity of just say 0.75 nanograms divided by milliliters per year, that's been shown to be associated with potentially having prostate cancer. But the only study was done in men who had a PSA between 4 and 10. And that's not all the men I see. And that didn't take into account the error of MRIs. And so PSA density wasn't in that study either. So things have changed a lot in terms of PSA velocity. But PSA velocity is a change in PSA over time.
But is there any family medicine to that, or just take the PSA and information and do
Over
it
time.
yourself?
Yep,
What the velocity is and talk
Correct.
to the urologist?
correct. Yeah, that's it. It's that simple.
Nothing to do with the velocity of the urine.
No.
Yeah, so I want to kind of on a humorous note, have you ever seen a prostate the size of a grapefruit?
Unfortunately, yes.
Wow.
Yeah.
That was shocking. I have a couple questions. Has there ever been proactive focal therapy without a diagnosis of prostate cancer?
No.
Okay.
Because and that's, it's an interesting question you're asking, but focal therapy is not without risks. And even though the urinary symptoms, the incontinence, the erectile dysfunction is minimized, patients still may have some frequency, some urgency, urinary tract infection. We still have to anesthetize them. What does that mean? Putting a tube in their throat, breathing for them while we're doing a procedure. So there's still risks, and so we want to minimize risks. And if someone doesn't have a cancer diagnosis, but to another point, is focal therapy needs a target, and that's why my conclusion.
The question, I mean, it's not whole gland at all. It's a specific lesion.
Well, it gets nuanced. Some people, I don't do whole gland focal therapy because the side effect profile of whole gland focal therapy equals other radical therapies, and radical therapy has more history of evidence. And so if I'm going to have equal side effect profile, but I don't know what the outcomes are going to be, I'd rather use a therapy that has long-term data supporting it.
Okay. My last question is, you didn't touch on what immunotherapy you're offering, or is it CAR T or?
So I personally don't offer immunotherapy for prostate cancer. It's a great question, but there's been a lot of randomized large clinical trials that have looked at the value of immunotherapy in managing prostate cancer, because it works for bladder cancer, works for kidney cancer, works for cancer that's sitting in the tube that drains the kidney. And despite a lot of interesting data on immunotherapy, research leads to bigger research, which leads to randomized controlled trials, which is the highest level of evidence for data. And the 9 randomized clinical trials on immunotherapy for prostate cancer were negative.
Okay, thanks.
Yeah.
I would like to ask a question. How would you explain that you mentioned to us that if the PSA is elevated in the younger age group, 40 around 50, but once it gets 70, 60, 70, the PSA goes down. I mean, it's lower. I think I saw that in your slide.
The PSA, oh no, the PSA goes up with age.
Yeah, I just don't know. How would you explain that?
It's an interesting point. I mean, it also coincides with the size of the prostate. So I don't want to assume my size of my prostate compared to yours, but I would say as we get older, prostates grow, and they continue to grow. That's why, I don't know if you've seen those movies where someone has difficulty peeing. It's not young men. It's usually older men. And it's because the prostate keeps growing. And
Yeah,
so,
the bigger the prostate, the PSA goes down.
no, it goes up.
Goes up, but in your slide, I don't know, no, but I saw it in your slide, and that's why I took note of that.
Oh, no, it goes up. I apologize if you saw that, but no, I don't think my slide said
Is
that.
there a connection of
It did.
prostate CA to testosterone?
What's that?
Is there any connection of prostate cancer
It's a good
to
question.
the level of testosterone?
Yeah, it's a great question. I would say, patients who have diabetes, are on dialysis, tend to have lower testosterone. And we just showed that metabolic syndrome is associated with prostate cancer. And so it would be interesting to look at whether or not low testosterone in this metabolic syndrome group is higher than low testosterone in the average population. With that being said, testosterone drives prostate cancer cells. So that's why when we treat prostate cancer that's spread out of the prostate, we give them medication that removes testosterone from their body. So there's a direct correlation. However, a normal testosterone level is not a driver of prostate cancer.
I did also want to mention that we recorded the seminar today, so if you register to provide us an email, we'll send the recording out to you. It might take you a few days to get that out, but we'll get that.
Can I ask you one question?
All right, thanks a lot for the seminar, appreciate it.
My pleasure.
I've had 2 MRIs, 2 biopsies in 2 years. Gleason score is 6, 3 plus 3. Should I keep getting them every year?
That's a great question. You're doing everything right, man. So just, kudos to you for seeing your urologist and getting checked. Now, I don't know how young you are, but you look pretty healthy.
70.
You're 70, all right. And are you getting more Gleason 6 cores? Because you said 2 biopsies. Is it increasing?
No, from both biopsies were almost exactly the same.
Okay.
It doesn't look like it has grown any at all. It's, from what I can see on the MRIs and versus what, I got the paperwork here for both biopsies.
Yeah.
And they took like 16 different biopsies or something like that, and they're both basically exactly the same.
Yeah, it's a good question, because you have to also ask yourself, well, how many cores are positive? Because that list that I showed you that said low risk, intermediate risk, high risk, it also takes into account how many cores are positive. So if you have 9 out of 12 cores that are positive for grade group 1, that's more than half. So you actually move to a new category. But if you only have 2 or 3, that's lower volume, so you stay in the low risk group. So I don't know how many cores are positive, but if they're low, then you sound like you're low risk. Unless your PSA is above 20 or is above 15 or something like that, that's kind of throwing everything off. But I would say if your PSA is low, less than 10, you have very low volume of grade group 1, Gleason 6, you've had negative MRIs, I think you're doing okay. I think you should probably just continue checking your PSA, and you probably don't need a biopsy for another 3 years.
Okay, yeah, it showed 1 positive, and PSA was running, I think, 7.5, 8, something like that, if I remember.
Yeah, just don't leave for 4 years to Cuba or something like that. Still, we've got to check your PSAs and make sure that your PSA density doesn't rise, because now we have data with your MRI, and we'll make decisions based on the PSA density and the MRI changes.
Okay, thank you.
You're welcome.
Okay, we've got about 7 more minutes for questions, so. Here we go. You can come in this way.
Just a simple question. Are these slides going to be made available?
I hope so. That was a good question.
Good morning. Thank you.
My pleasure, guys.
Is there an alternative to an MRI? I have brought some evidence. I mean, if I go up and there's a bacteria residence and I know it's full, I don't want
Yeah, no, we don't want you to explode. That's a great question. That's a very important question. Yes, there are alternatives. There's micro-ultrasound. Micro-ultrasound is a new way of looking at the prostate with more detail than an ultrasound. And so some centers do micro-ultrasounds, and it's very easy to do. And it's, you don't need to, if you have metal in your body, it's just micro-ultrasound's newer, so people are less skilled at evaluating it. The benefit of MRI is that we have radiologists, like imaging doctors, who read the MRI and give us a report, whereas a micro-ultrasound, it's the urologist that has to do it. And so if you need further imaging, you should go to a center where they use micro-ultrasounds routinely. You're welcome.
Thank you very much.
My pleasure.
If I go to my first exam, what do I expect to get? What procedures are done and what information will I get?
It's a good question. I mean, if there's been a move towards not doing a digital rectal examination if you have an MRI. An MRI, when you think about a sphere, my finger can't go all around your prostate. And so I can only feel maybe 1/5 of the circumference of your prostate. And so prior to the use of MRIs, this is how urologists used to try to check for abnormalities. And so that's the jokes with urologists with the finger joke. But now we have MRIs that tell us so much information. And so the value of a digital rectal examination, I don't want to say it's not valuable, but an MRI gives you so much more information. So if you're coming in with an MRI, you're probably not going to get a guy or a urologist put a finger in your rectum as well. You're going to have a conversation. There's no physical exam that I can think of that will sway me into the type of procedure I should do, other than, of course, making sure that A, you haven't had major abdominal surgery, B, I don't want to do radical therapy in a patient who has a life expectancy of 2 to 3 years, because I'm putting them through a lot, and he has other competing risks that he has to focus on, right? Prostate is second to a heart attack. It's second to a stroke. So if someone has had a stroke in the last year or last 6 months, what am I doing trying to treat their prostate cancer? This is what poses, this is what poses an immediate risk. So there's some things that they may ask you, your past surgical history, your past medical history. If you've had a PSA, you need another one. You're gonna go see a urologist after one PSA, he's just gonna say, go get another one. Yeah.
Thank you very much for taking my question. I was just trying to figure out what the symptoms are that we start monitoring the PSA and the prostate and all that thing. What do we ever look for?
Yeah.
What the symptoms?
I love seeing proactive patients. So unfortunately, if you have symptoms of prostate cancer, then it's too late. However, patients have BPH, which is benign prostatic hyperplasia, which is just the movies where people have difficulty peeing. And just because you have symptoms and prostate cancer doesn't mean you have symptoms from prostate cancer. Because prostate cancer grows on the outside of the prostate, and BPH, which is the benign growth of the prostate from just aging, happens in the middle of the prostate. And it just so happens that the urethra, how you pee, goes through the middle of the prostate. And that's why men who have big prostates, on average, have urinary symptoms, because it's pushing on their urethra and making it harder to pee. So prostate cancer grows on the edge, which is far away from the urinary system. And so that's why people, I feel fine. You hear that a lot, I feel fine. You should feel fine. And if you don't feel fine, then we got to figure out why.
All right, we have time for one more question. Anybody?
Here.
All right, we got one.
You said about in the asymptomatic man, what that definition was?
Symptoms would be what? Symptoms of prostate cancer. Usually it would be when they have advanced disease. So it may be similar to someone who has BPH, difficulty peeing, frequency, urgency, blood in the urine, blood they can't see but that's present on urinalysis, and that happens, bone pain, lower back pain, things like that. But those are the concerning ones.
why the family medicine doctors normally, they say, okay, you're old, well, you have a problem with the prostate, enlarged prostate, but they don't go much into diagnosis of, is any guidelines for the family doctors or the patient has to know? Because normally most of the family doctors just ignore till it becomes worse. Then the urologist, we have to run to.
It's a tough question. I mean, I want to assume that since 2019 and with the U.S. Service Preventative Task Force change, I want to assume that the education to family physicians has changed. With that being said, you don't want, we have guidelines, the American Urology Association guidelines, which gives age-associated determinations of what's a concerning PSA, when to stop PSA monitoring, and how often to monitor PSA based on the number you get.
How can we find that guidelines for us?
Google, American Urology Association, yeah.
How about the family medicine requirements if they have to diagnose any problem?
It's
just high, when he says 6.5, he said, okay, it's normal for your age, that's all they say. But they cannot say more than that, that's what else. Then you have to run to the urologist and find out.
We're happy to help. I mean, if that's our job. So if you aren't sure, then you send it to us. Happy to help.
Because normally the family doctors, as a patient, is there any guidelines for the family doctors? Say, hey, this is, you have to go.
So, absolutely. I mean, the
They
American...
don't say anything. They say high, low, and that's it.
Yeah, the American Urology Association guidelines are for the general urologist. They're very simple. We're plumbers by nature. We're very simple-minded, right? So they're not hard to read. It's 2 to 3 pages, So I would encourage you to read it.